You just heard a Wegovy pill exists, and your first thought was probably, finally, no needles, no refrigerator, no weekly injection. But here is the thing. The pill and the injection are not interchangeable. There is one number that separates them, and most people making this switch never hear it stated correctly. That number is the reason this comparison is harder than it looks. Both forms contain the same active drug, semaglutide, the GLP-1 medication that reduces appetite and slows digestion. The difference is delivery. And delivery turns out to matter far more than most coverage suggests, especially once real-world use enters the picture. Before getting into the numbers, it is worth understanding why delivery is not just a minor detail. It is the variable that determines whether the drug actually works. I'm Dr. Kim. This is not medical advice. Consult your doctor. The gap between the pill and the injection is not about the molecule. It is about what the body does with it after you take it. The injectable Wegovy, 2.4 milligrams weekly, produced a mean body weight loss of 14.9% over 68 weeks in the Step 1 trial, which enrolled nearly 2,000 participants. The pill, 25 milligrams daily, was tested in a large clinical trial, enrolling 306 participants. The primary result at 64 weeks was a mean weight loss of 13.6%. A separate analysis restricted to participants with full adherence showed 16.6%, and about 1 in 3 of those fully adherent participants lost 20% or more. That is an important distinction. The headline number from that trial is 13.6, not 16.6. That is the number, 13.6 versus 14.9, a gap that looks small on paper but gets larger the moment real-world adherence enters the equation. So here is the clean takeaway. The injection won on the primary result, and the pill looked closer only when adherence was especially strong. The two trials are not directly comparable. Different designs, different durations, and a 6-fold difference in sample size mean any side-by-side reading of the percentages should be taken with caution. Here is why the pill is tricky from a chemical standpoint. When you inject semaglutide under the skin, it forms a small depot and releases slowly over the following week. That slow, sustained release gives the injection predictable weekly exposure and highly consistent absorption. The pill takes a very different route. It has to survive the stomach, get absorbed through the gut, and then pass through first-pass metabolism, a filtering process in the liver, before reaching circulation. The tablet contains a special absorption-enhancing compound that temporarily neutralizes stomach acid to allow more drug through. Even so, only about 1 to 2% of the oral dose reaches your bloodstream. That is why the oral formulation requires a much higher dose to achieve a comparable effect. And the absorption is highly variable between individuals, meaning two people following the same protocol can end up with meaningfully different drug levels in their system. And because absorption is this sensitive, the rules around taking it are strict. You take it first thing in the morning on a completely empty stomach with no more than 4 ounces of plain water. Then you wait at least 30 minutes before eating, drinking coffee, or taking anything else. Take it with food and absorption drops dramatically. Take it with coffee, and absorption can drop there too. For some people, that morning protocol is manageable. For others, it becomes the single reason the pill stops working. You wake up, already running behind. Coffee is ready, kids need breakfast, the pill is on the counter. You take it, drink the coffee anyway because you forgot, and you are out the door. That is not a failure of willpower. That is just a Tuesday. What makes this harder is that the pill does not announce when it has been taken incorrectly. There is no immediate signal that absorption was low. The medication feels the same going down. The only feedback comes weeks later when the scale is not moving the way it should, and by then, most people blame the drug, not the coffee. Weekday routines are one thing. Weekends are where the protocol tends to break down. Sleep schedules shift, mornings start differently, and the structured sequence that worked Monday through Friday gets skipped or compressed. Over time, Even a few poorly absorbed doses per week can meaningfully lower cumulative drug exposure. There is a pattern worth knowing about, and it shows up in something most people overlook entirely. In drug research, the gap between what a medication can do and what it does in real-world use almost always comes down to how reliably patients take it as directed. For the Wegovy pill, that means every morning, fasted, same time, no exceptions. The injection does not have that problem. Once a week, any time, with or without food, absorption is highly predictable. The side effect picture is worth clarifying. Both forms activate the same receptors, so nausea, early satiety, and occasional vomiting come from the mechanism, not the delivery method. Gastrointestinal complaints are the most common in both groups. The rarer but more serious risks, thyroid concerns, pancreatitis, gallbladder disease, appear at comparable rates with both formulations. There is one more comparison most people never think to make, and it changes how you interpret the pill data entirely. Before this pill existed, some patients were already on oral semaglutide, Rybelsus, approved for type 2 diabetes at up to 14 milligrams. The obesity pill is nearly double that dose. This matters because people online often treat all oral semaglutide as equivalent. They are not. The lower diabetes dose produces modest weight loss. The obesity dose pill is a different category entirely. If someone says oral semaglutide did not work, the first question is which dose they actually took. One more factor. The pill is sensitive to moisture. Each tablet needs to stay in its blister pack until you take it. Humidity can degrade the tablet and reduce absorption. For frequent travelers or anyone using a pill organizer, that is friction the injection does not have. In practice, patients with structured morning routines tend to do well with the pill. Those whose mornings are unpredictable or who travel frequently tend to find the injection easier to sustain. The data puts both forms reasonably close, but the pill's best numbers come from analyses where adherence was tightly controlled. In real-world use, that is not guaranteed. If you have needle aversion and a consistent routine, the pill is a real option. If you want predictable absorption and have no issue with injections, the injection still has the stronger primary result. The most effective medication is the one that gets taken correctly, every time. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.